So here you are watching drug-induced sleep endoscopy with this monitoring in a 55-year-old male with history of snoring and choking. He has been operated long time back for the nose, but he still has got a deviated septum on the right side, and he has nose blockage as well. His body mass index is 29, so he is a little overweight, and his apnea-hypopnea index is 30, which are mostly apneas. Now, as I go from left side, you can see the turbinate hypertrophy. Obviously, the turbinate was not addressed during the previous surgery, which was done long back. As we go further inside, there are no adenoids. Salpingopharyngeal folds are grade 0 by Edwards classification, so they are not significant at all. Now, this is in the correct range around 77, 75. So, and at this base, you can see soft palate is collapsing in the lower part. So, it's a funnel kind of collapse. So, there was a little collapse of the baseline and the epiglottis, which I'll wait to see again. There is a multi-level collapse. This is in the correct range, so we have not over-sedated him. His mouth is also closed. He's not breathing from his mouth right now. You can see almost a complete collapse of the anterior-posterior collapse of the velum. With slight collapse, partial collapse of the base tongue and the epiglottis. Now you see him snoring, and you could see that the epiglottis was collapsing primarily. So we have to wait for the pattern to emerge. We cannot just take one finding and then decide what is the issue. We have to wait for the pattern. One episode of the epiglottis collapsing primarily does not make it a primary epiglottic collapse. Here you can see that the base tongue is also a little collapsible. Palate is 100%. The velum is 100% collapsing, which is more AP. And with that, you can see that when the palate is collapsing, his epiglottis has also collapsed twice or thrice as a primary epiglottic collapse. Now I'll close his mouth more forcefully and then see what is happening. Now I'm closing his mouth forcefully. The base is in the correct range around 70. At this point of time, you can see that the palate was collapsing and the epiglottis periodically collapses as a primary collapse. That's because of Bernoulli. Obviously, it does not require a correction because it's only the Bernoulli which is producing. It's not collapsing every time. Because of the Bernoulli is that the epiglottis is getting pulled. His tongue base is not large enough to be operated. BMI is 29, so he has to reduce his weight, and the tongue will also improve. But you can see with the soft palate collapsing because of Bernoulli, at times his epiglottis gets pulled inside. There's no lymphoid tissue on the base tongue, almost nothing. What it requires is a nose correction and palate correction The first we are doing is nose surgery, which will improve his nasal pathway. And second we can do is palatopharyngoplasty, because he does not want to get both done in the same stage. The second stage we'll do a uvulopalatopharyngoplasty, and we might strengthen the median glossopyglotic ligament, which is a 5-minute job. Though after doing the palate, it may not actually collapse. So that is an option that can be given to the patient. But palate surgery is for sure required, because right now his mouth is closed and still it's collapsing. And this is in the correct range, 76. Alright. So this is the perfect stage of sleep. This is the correct assessment. But majority of the times you can see that his soft palate, the epiglottis is also collapsing. So you might do uvulopalatopharyngoplasty suspension with variety for both AP as well as lateral, though it's more AP, less lateral. But along with that, we can perform glossoepiglottoplexy. Now we can try putting in a nasal airway and see what happens after bypassing the soft palate. Will this, yeah, this epiglottis, which is getting pulled inside with Bernoulli, if I take care of the, right, if I take care of the soft palate, bypass the soft palate by putting in an airway, we'll try to see whether, and see the length of the velum, pretty long velum. So let me put a nasal airway. Obviously, this will wake the patient to some extent. We'll have to wait for him to go to sleep again. But just give me a moment. I'm putting in the nasopharyngeal tube, and I'll go through the nasopharyngeal tube to see inside what is happening to the epiglottis after we have bypassed soft palate. Now the nasopharyngeal tube has bypassed the soft palate. Alright. Now let's see what is happening to the epiglottis. This is soft palate. You can see that the soft palate, the epiglottis is still collapsing. So that gives us the indication that even after doing a palate surgery, the epiglottis will possibly still require a treatment. Therefore, we should do a glossoepiglottopexy along with palatal surgery. Can you see that? So this is a confirmation that yes, his median glossoepiglotic ligament will require treatment even after we do the procedure for the soft palate. So we should do it at the same time. Alright, so then the required procedure will be suspension bridge pharyngoplasty with glossoepiglottopexy in the second stage. In the first stage we are doing is correction of the nose. Alright, and you are pretty sure that the tongue base is not collapsing. It does not require a surgery for the tongue base, it's primarily epiglottic collapse. And now it is very, very clear. The base is in the range of 74, it's not very low. Right? We have bypassed the soft palate and still his epiglottis is collapsing most of the time. Thank you for watching.